Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello, I am Dr. Amasika Nyaku, Assistant Professor at Northwestern University Feinberg School of Medicine. Welcome to Clinical Clips from IAS 2025, Episode 3 of 4. So first, I'm going to start off with having us take a deep dive into the details of the PURPOSE trials. And as a reminder, the PURPOSE 1 and 2 trials, the magnificent findings have been what has led to the approval of lenacapavir for HIV prevention. So first, we'll start with an abstract that was focused on how did they estimate the HIV incidence as the marker to test the efficacy of lenacapavir for HIV prevention. So in the setting of now active placebo-controlled trials, there needs to be new mathematical methods to determine the threshold for non-inferiority or in some cases superiority. And so using a counterfactual incidence design is needed. And this has been used quite frequently in contraceptive testing. They used a recency assay with a recent infection testing algorithm, or RITA, to estimate the incidence of the background HIV, and then compared that to other methods that are used to try and estimate what is the incidence of HIV. Overall, what they found was that the RITA-based estimation was actually a pretty conservative estimate of the background incidence of HIV when compared to that incidence estimates derived from other trials, but that actually ends up being a positive and strengthens the findings from the PURPOSE 1 and 2 trials. Now I'll shift so that we look at some of the sub-analyses. First is looking at the efficacy, safety, and pharmacokinetics of lenacapavir in adolescents and young people. And this is pooling the results from both PURPOSE 1 and PURPOSE 2. And so in this sub-analysis of the PURPOSE 1 and PURPOSE 2 studies, they defined a youth as an individual between the ages of 16 to 25, and then compared the outcomes in the youth population as compared to the adults. The bottom line was that lenacapavir was highly efficacious in the youth population. There were 0 infections in PURPOSE 1, and there were 2 new HIV infections in PURPOSE 2. In terms of the safety, it was well tolerated and overall safe, and that was considered to be similar as what they observed in the adult population, and there was overall high acceptability. And then in terms of the therapeutic levels of lenacapavir, those were similar, again, between youth and adults, and so there doesn't need to, this is one of the reasons why there's not any indication for any body weight adjustment. Now, I want to move us to looking at what are the preferences between receiving twice yearly injections versus daily oral pills in the PURPOSE 2 study. So in this analysis, participants were surveyed at baseline, week 26, and week 52. And at all 3 of those time points, there was a high survey response rate. Across all 3 time points, 75% of participants, more than 75% of participants preferred the twice yearly injections and felt that twice yearly injections were likely to support their future adherence to PrEP. When they tried to understand what were some of the motivations around preference, in terms of the pills, participants that preferred pills reported preferring the pills because they had concerns about pain or discomfort associated with the injection. Whereas the participants that preferred the injection, that was primarily motivated by their perceptions of the injections being more efficacious, convenient, and being able to help them remain adherent to PrEP because it was only twice yearly dosing. Last but not least, out of this deep dive into the PURPOSE studies, we're going to look at the sub-study of the safety, efficacy, and pharmacokinetics of lenacapavir in pregnant and lactating people. So there were 184 pregnancies in the roughly 2,000 women that received lenacapavir. And in those women that became pregnant, there were 0 HIV infections. Across the other arms, there were several pregnancies, and of those pregnancies, 5 participants did become pregnant, or 5 participants did acquire HIV, but there were no cases of vertical transmission. When they looked at pregnancy outcomes, they were similar across all of the different arms, and lenacapavir was deemed to be safe during pregnancy. There wasn't any increased adverse events or injection site reactions in pregnant participants as compared to non-pregnant participants. One of the critical findings in this sub-study was related to the pharmacokinetics of lenacapavir. Pregnancy did not significantly alter the lenacapavir levels in the maternal plasma. And so overall, taken together, lenacapavir is deemed safe in pregnant and lactating individuals, and again shows that it was very effective in terms of preventing HIV infections, particularly in pregnant individuals. Now I'll shift so that we can look at some of the data that evaluates disparities in new HIV diagnosis in the United States. In their analysis, using publicly available data, residential segregation was associated with an increased HIV incidence rate in all of the regions of the US except for the Midwest. These findings are very important because it adds to the body of evidence about the impact of systemic racism on infectious disease outcomes and highlights the need to include factors like residential segregation and other markers of systemic racism in research, as well as in national initiatives, particularly those that are focused on ending the HIV epidemic. Next, we'll look at unmet PrEP need in 3 African countries. So adolescent girls and young women in Eastern and Southern Africa have 2 to 4 times the incidence of HIV as compared to young men. In this study, they compared the PrEP access, so they defined that as getting their PrEP prescriptions filled, to the number of new HIV diagnoses among young women and men in 3 countries in Eastern and Southern Africa. So when the PrEP to new diagnosis ratios were compared by sex, young women between the ages of 15 to 24 had 58% less PrEP access relative to the need compared to young men of that age group. When the PrEP to new diagnosis ratios were compared by age, young people overall between the ages of 20 to 24 had 37% less PrEP access relative to their need as compared to young people between the ages of 15 to 19 years old. As efforts to scale up PrEP continue to be a priority, it's necessary to maintain a continued focus on getting PrEP to those that need it the most to reduce the disparities in HIV incidence. And so using these types of markers around PrEP need and PrEP equity can help as a way to continue to monitor whether or not PrEP is getting in the right hands. Now let's look at what ends up being a programmatic review of the USAID supported PrEP introduction and scale up. So 3.7 million people across 43 countries initiated PrEP, with 92% of those PrEP initiations happening after fiscal year 21. USAID ultimately was responsible for implementation of 47% of global PrEP programs, and roughly 36% of PrEP went to adolescent girls and young women. And then another 1 million of PrEP prescriptions ended up going to key populations, such as female sex workers, men who have sex with men, transgender persons, and people who inject drugs. Ultimately, this review reflects the entirety of the USAID program. And so with that, I'd like to thank you for joining us for episode 3. Please refer to the landing page for slides and to claim your continuing education credit. Please be sure to come back tomorrow for our 4th and final clinical clip from IAS 2025.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.